My first talk today is on kidney preservation for upper-tract urothelial cancer, talking about some of the rationale, where we are right now, and some of the directions that we can go in. I do have two relevant disclosures for this talk. The first is I was a study site investigator for one of the clinical trials that looked at chemoablation for upper-tract urothelial cancer, and I'll refer to that study when I get to it. And the other is that I'm on the AUA Upper-Tract Urothelial Carcinoma Guidelines panel with the guideline coming out in May of 2023. So as many of us know, upper-tract urothelial cancer is an uncommon genitourinary malignancy. It's about 7% of urothelial tumors as distributed in both the renal, pelvis, and ureters as shown in the figure. The representative pictures both endoscopically, pathologically, and radiographically are shown. Over the past 30 years, there has been an increase in the number of cases of upper-tract urothelial cancer. This is a SEER-based study that we did about 8 or 9 years ago. And the preponderance of what we're seeing for upper-tract disease is identifying and finding more in situ tumors. So sort of a staged migration towards more in situ or earlier stage disease. So I want to use that as a framework really for two objectives today. The first is to talk about nephroureterectomy and highlight that it really is a procedure that has morbidity, and then use that to sort of set the stage for the concept of kidney preservation, when it might be appropriate, where we are, and then where we need to go perhaps. So let's start with the first of these. Nephroureterectomy is not without morbidity. So I'll be the first to tell you that it is the gold standard for bulky, high-grade, multifocal and invasive upper tract cancers, and that's really because the entire upper urinary tract on the ipsilateral side is at risk. But look, these patients are elderly, they're comorbid, they have medical problems, there's a reason they developed upper tract tumors, many have tobacco exposure, metabolic syndrome, environmental exposures. So I think about this population much more like a radical cystectomy population that's actually undergoing sort of a glorified nephrectomy. Sort of underscoring this point is a paper by Quan Lin from a few years ago looking at 100 patients who underwent nephroureterectomy and really found that many of them have comorbidities, high blood pressure, diabetes, coronary artery disease, pulmonary issues, as well as other medical problems. So I think we all have to recognize that this is an ill patient population that is at risk for complications. So you might say, well, what are the complications? What's the risk? What's the likelihood? I think it depends on what you look at. So I think if you look at large population data sets, which are sort of extracted from large volumes of cases, both academic as well as those in community practice, you'll see one set of numbers that I think is reflective of the case mix that's coming there as well as reporting bias. And then you'll see something different, perhaps higher numbers, frankly, at academic health systems. So let me give you both ends of the spectrum. So this is a nice paper by Pierre Karakowicz, looked at the nationwide inpatient sample, and they were comparing lap versus open nephroureterectomy. And I would just say, probably not relevant to do, just look at overall numbers. Overall complication rate from this study, about 15% with a 1% mortality rate in hospital. So that doesn't sound too bad. But then if you look at, for example, what you see maybe at some academic health systems, so this is the data out of MD Anderson, Serena Mateen published it. He published in his series 50% complication rate after nephroureterectomy, of which 15% of these were major complications, Clavien 3, 4, and 5. So maybe you say, well, maybe that's just the MD Anderson experience. What about the rest of the world? About 5 years ago, we pulled data from about 4 US institutions, 4 in Europe. So we had 8 academic medical centers, 700 patients, and the numbers are fairly similar. There's about a 40% complication rate after nephroureterectomy, and about 10% are really significant. They're major complications. And as with anything in this day and age, you can sort of build a nomogram, but let me just give you maybe the average upper tract patient that we see. It's a 70-year-old male, Caucasian, performance status of 2, comorbidity index, Charleston of maybe 3 or 4, CKD stage 3. That patient has about a 65 to 70% chance of having a complication after nephroureterectomy. And I think it's sort of eye-opening to think about that and hopefully valuable actually when you're counseling patients. So my take home is, look, depending on your practice environment, I think the complication rate after nephroureterectomy is 20 to 40%. And I think we need to be able to counsel our patients that the risks of RNU are really quite significant, and frankly, they're far more significant than what we report for the kidney cancer population who are undergoing partial or radical nephrectomy. So I kind of want to use that framework to hopefully convince some of you that we should be thinking more and more about kidney preservation and some of the tools and techniques that I think can be valuable in that realm. So this is a paper from Kareem Chamie from a few years ago from UCLA. This is looking at the National Cancer Database. And what he identified was if you look at patients who have low-grade tumors, low-grade upper tract tumors, only about 20% of them were managed endoscopically. It's only a fifth, so it's a pretty low number, actually. So this is data from a large collaborative that I was part of. This is a nephroureterectomy data set. And we looked at the pathology of these tumors that were removed, and what we identified was about a third of them were low grade, and about 20% of them were TA. Now, I'm not going to tell you every TA and every low-grade tumor needs to be managed endoscopically, but I do think that there's an opportunity to manage some of these endoscopically. So I think when we talk about kidney preservation for upper tract tumors, it's important to distinguish between imperative and elective indications. So what's an imperative indication? Anatomic or functional solitary kidney, significant chronic kidney disease, bilateral upper tract tumors, or just a patient who's so medically comorbid that they're not going to make it through a major operation. But I think what most of us see in practice is really the elective cases, really those patients maybe who have low-risk upper tract tumors, or maybe a few select high-risk upper tract tumors. So you might say, well, what do you mean low risk? What does that mean exactly? What is a low-risk upper tract tumor? I think it's important to recognize low risk is not just the tumor, it's the patient, the imaging, and the tumor. So for example, a low-risk patient is really one that isn't actively smoking. It's one who doesn't have environmental exposures, someone that will actually come for surveillance and follow-up for their examinations. Radiographically, I don't think we want to see imaging where we see hydronephrosis or any periureteral or perinephric stranding to suggest that this may be invasive disease. And then you get more to perhaps the tumor-specific variables. Smaller is better, centimeter, centimeter and a half. Unifocal, better than multifocal. And then certainly, I think when you think about low grade, you're really looking for low-grade tumors with negative cytology. I don't think we really want to be routinely doing endoscopic management for high-grade tumors because there is data not only of recurrence, but also for progression. So I think this is a really nice schematic. Firos Petros published this in Urologic Clinics. And the way it breaks it down is, what I circled right here is bucket number one. This is your imperative indications. And I kind of highlighted for you what those imperative indications are. And I think for imperative, unless there's a great reason, I think endoscopic management really should be the way that we lead off with these patients as much as possible. Bucket two, these are your elective indications, but elective low risk. And I think these patients, when appropriate, are very reasonable to try endoscopic management, understanding that if there's progression in grade, stage, or even tumor burden, that these patients might need more definitive therapy in the form of surgical removal. And then you get to the high-risk bucket. And I think the high-risk bucket really she needs to go to nephroureterectomy or some type of surgical extirpation. I feel like unless you're in some sort of heroic circumstance, endoscopic ablation is likely going to fail over time. What's some of the rationale behind this? So we talk a lot in the kidney cancer world about chronic kidney disease and partial and radical nephrectomy. But guess what? If you look at upper tract patients, their baseline estimated GFR before you treat them is about 65. It's far lower than the kidney cancer population. And after you do a nephroureterectomy on them, over 50% of them are going to have stage 4 chronic kidney disease. So we have to be cognizant that chronic kidney disease and all the resultant effects may be even more significant in this population. There's also some data that says maybe endoscopic ablation may be more cost effective. So this is data from Jefferson. Ray Pack published this back in 2009, and they made some assumptions. So they took a solitary kidney model, and they said this person has upper tract, and we're going to do a nephroureterectomy, and then this person's going to go on dialysis for 5 years, and they estimated the costs. And then they said, same patient, upper tract tumor, we're going to manage it endoscopically, and then we're going to assume worst case scenario. Every single time we come back to do ureteroscopy, there's going to be a recurrence. So they assumed the worst case scenario, and we're going to manage each of those. When they compared those two scenarios, even if they recurred every single time endoscopically, it was about $250,000 less cost over 5 years, and this is 2009 numbers. So there may be some cost benefit. But here's really what we need to tell patients, that there is a high likelihood of recurrence. If you manage these tumors endoscopically, there is a high likelihood of recurrence. So this is a pooled analysis of almost 600 patients followed for about 24 to 58 months. And I think the key take-home numbers are, number one, likelihood of ipsilateral upper tract recurrence is about 65%, so 2/3. Likelihood of bladder recurrence is about 40 to 50%. And up to about 1/3 of these patients may progress to nephroureterectomy over time. So key take-home is, look, recurrences occur after you endoscopically manage these upper tract tumors. And why do they occur in the ipsilateral upper tract? I think it's a variety of factors. I mean, I think that, look, the kidney and the calyces are complex. Number one, the ureteral diameter is narrow. When you start endoscopically ablating the tumors, you might get bleeding. It gets harder to see. There's the risk of seeding. You might not see all of the tumors. And really, even though ureteroscopic equipment, optics, and lasers have gotten better, these are still small tools, and there are some inherent limitations. So I think sort of highlighting this point, this is some really nice data from Olivier Traxler, and he's probably one of the most skilled endourologists, and he reported very honestly that when he took patients and endoscopically ablated their tumors, and they came back, about 8 weeks later, 50% of these patients still had tumor in the ipsilateral upper tract, 80% of which were in the same location. So this really highlights that if you're going to use endoscopic management, you need to bring them back for this second look within about 8 to 12 weeks, because chances are you may not have cleared out all of their disease right out of the gate. I think there's also the real concept of bladder seeding. And I think this has been shown very nicely from a number of papers. But I think the key take-home message is this analysis here. So what this looked at was patients who had an upper tract tumor who went straight to nephro-U versus those that had an upper tract tumor who first had ureteroscopy and then they had a nephro-U. And the group that had ureteroscopy had a 1.5-fold higher risk of subsequently developing bladder cancer, really sort of highlighting there might be a downstream seeding effect that's occurring. And this effect really appeared to be irrespective of if the patients had a prior bladder cancer history or if you manipulated the tumor. So simply putting a wire up, positive pressure irrigation from ureteroscopy appeared to result in some downstream seeding, even if you didn't biopsy the tumor at the end of the day. So how do we get around this problem? Well, I think we can pull some of the information for what we do for nephroureterectomy and kind of apply that to what we do for ureteroscopy. So in nephroureterectomy, there's great randomized prospective level 1 data that shows if you give bladder chemoprophylaxis after nephroureterectomy, you're less likely to develop a bladder tumor. Probably the sentinel study is the ODMIT-C trial. This is from Tim O'Brien from the UK. What he basically did was a randomized prospective trial out of the UK. Patients who had a nephro-U were randomized 2 weeks at the time their catheter came out in the office to either have a single dose of mitomycin in the bladder versus just saline. And he followed them for a year, and there was a 40% risk reduction in those patients who got a single dose of mitomycin at the time the catheter was removed. Now, you may not need to even wait that long. So there is some good data, both in the bladder cancer literature, as I'm showing on the left, as well as in the upper tract literature on the right, that actually sooner might be better, that if you actually give the therapies in the bladder at the time or right after the procedure, that may be better and decrease your chance of recurrence versus waiting 1 or 2 weeks or a delayed installation in the bladder. And finally, I think there's some great data that shows that gemcitabine is a very viable option. So this is the Messing study in JAMA from a few years ago. Again, bladder cancer study, but basically randomized patients to intravesical gemcitabine versus placebo and followed them and identified a lower likelihood of bladder cancer recurrence after TUR. And the advantage of gemcitabine versus mitomycin are twofold. Number one, gemcitabine is far, far cheaper. Number two, gemcitabine is far more inert, meaning a lot of the bladder toxicity is obviated. So practically speaking, what do? If anybody has an upper tract tumor that I'm endoscopically ablating, at the end of the case, I put a catheter in the bladder, I empty the bladder, I put 2 grams of gemcitabine and 100 cc's of normal saline, and I clamp the catheter for an hour, and then I release it. This is being studied. There's a trial called the Gemini trial. This is coming out of Iowa that's investigating this, and I think we'll get some actuarial data on how effective this practice is. Well, what about topical therapy for the upper tract? So we use a lot in the bladder. It works really well. The data is compelling. So I talked to you earlier about endoscopic ablation has the likelihood of disease recurrence in the upper tract. Here are some of the data, anywhere between 50 and 90% likelihood of disease recurrence. And if you look at giving BCG or mitomycin in the upper tract, okay, sure, maybe it's a little bit lower, but it's not certainly anything that's overwhelming with regards to a treatment response. Why is that? Really dwell time. You put drug in the upper tract, it's eluted from the upper tract within about 10 or 15 minutes. There's also the questions of how do you give the drug? Antegrade, retrograde, reflux with a stent. What's the optimal agent? BCG, mitomycin, gemcitabine, or something else? For example, in the immunotherapy realm, how many instillations do you give? And do you give it adjuvant or ablative? Adjuvant means you give it after you ablate the tumor endoscopically. Ablative is you just don't do anything to the tumor, you let the drug take effect. And there are different mechanisms of doing it, drug-eluting stents, thermosensitive polymers. I'm going to talk about the thermosensitive polymers because that's a trial that I was part of. So this is sort of made by Urogen, which is the company. And the concept of this gel is really kind of interesting. It's the opposite of Jell-O. So Jell-O is liquid at room temperature, and then you put it in the fridge and it becomes gelatinous. The gel works the opposite way. It's liquid at cold, and when you put it into the human body, it becomes more gelatinous. So it conforms to the upper urinary tract, and therefore it allows a higher dwell time and concentration that contours to the renal calyceal system. Almost 4 times higher effect or mitomycin concentration compared to if this drug was just in saline alone. And so that sort of sets the stage. This was what we published in Lancet Oncology a few years ago. This is the Olympus trial, a chemoablation trial. So tumor in the tract, trying to see whether this drug could ablate the tumor. Inclusion criteria, low-grade tumor in the upper tract, relatively small lesions, had to be above the renal pelvis, so we did not treat ureteral tumors in that study. And they had to have visible tumor, meaning they had to have an index tumor that we could follow. Trial mechanism, induction course of 6 weeks of therapy, so once a week for 6 weeks, you would put, in our case, retrograde installation of drug into the kidney. You'd check them once a week for 6 weeks, so you'd repeat the procedure, 6-week holiday, then a primary disease evaluation at 6 weeks thereafter, that's by ureteroscopy, assess primary disease response, and then go on with maintenance therapy in those that elected it, but you would have to do ureteroscopy every 3 months to assess for durability. Key take-home points from this study. Look, I think most of these patients had multifocal tumors, and where do I think the real value of this therapy is? About 50% of these tumors were not reachable with a laser, so they were tucked in some calyx in the kidney that was not readily accessible. In my opinion, this is really sort of the potential value of this therapy. And what's the data show? Complete response rate at that first initial visit, 59%. So 59% complete response. And if you said, well, of that 59%, how many were durable? 80% remained durable at 12 months. But it comes at a cost, and the cost is the potential for ureteral strictures. And it's not an insignificant risk. It's about 15%. I think some of this was trial related. It was a 7 French ureteral catheter that we had to use in the trial. That's a big catheter to be putting up there week after week. So I've personally changed my protocol a little bit to make it less of an insult. So what's the take-home from the Olympus? Look, we could do prospective multi-center trials. Delivery mechanisms can enhance drug efficacy, but I still think we need to figure out what's the right drug, the right dosing, the right duration, and really what is the most appropriate indication, ablative or adjuvant. So my conclusions from this talk is I hope I've been able to convince you that kidney preservation has a role for appropriately selected patients with low-risk upper-tract urothelial cancer. Endoscopic ablation is successful, but we have to accept that there is a natural history of disease recurrence. I'm a big believer that if you are doing endoscopic ablation, you should give some intravesical chemotherapy at the end of the case to decrease your likelihood of bladder tumor recurrence. And I think chemoablation is one approach, and there are others, that can help treat the index lesion and the entire ipsilateral urinary tract. Thank you.